Thank you, Dr. Saima, and thank you, the organizers, for inviting me for this talk. I know because of the short of time, we have to be very quick. And I have no disclosures, and this is the outline of my talk. We know that breast cancer is the commonest cancer worldwide, and it is associated with high mortality, and it is more prevalent in transitioning countries like Pakistan as compared to transition countries. Now, the histologically and molecular subtyping, breast cancer is a very heterogeneous disease, and that reflects in the treatment outcomes of the breast cancer. And we want to know some imaging modalities which can differentiate prehand to foresee the treatment. Now, for staging purposes, we can use ultrasound and other modalities to different. However, the PET can be utilized for facilitating breast cancer staging, distant metastasis detection, prognostic prediction, and also evaluation of the pathological response to the treatment. Now, the objective assessment of the tumor response and treatment results has been basis for the advancement of the cancer therapies. The RESIST was introduced in 2000 and then revised in 2009. And for the last 2 decades, this has been the mainstay for all the trials which has been conducted. However, the RESIST has got so many challenges, and I'm not going to discuss all these things, but basically it fails to reveal the viability of the tissue. There are measurement variabilities, and also it lacks the concordance between the response evaluation and the time to interval outcome, like progression-free survival, overall survival and disease-specific survival. Now, the functional assessment of a tumor, the basic for is that FDG has emerged as a useful tool capable of providing prognostic relevant imaging biomarker. It is observed in malignant tumors and usually related to proliferative activity and tumor cell viability. Now, the PERCIST, which was defined in 2009 by Wall, it utilizes early metabolic signature and capture on FDG PET. It also introduces standardization and addressing multiple serious sources of variability, and also it can differentiate between true and false response. Now, this is a cartoon which was published by Paria recently, and it shows the protocol for PERCIST, and I'm not going to discuss it because it's available in the literature. And then there are various forms of PERCIST, and basically PERCIST 1 defines the responses, and it has been modified, and then for immunotherapy it has been modified to iPERCIST. Basically, it is used for metastatic breast cancer responses and also post-neoadjuvant chemotherapy. There are few studies on PERCIST which are available on the literature, and this was the first study which was a prospective trial from Sloan Kettering, and it shows that the 40% of the RESIST non-responders were PERCIST responders. PERCIST were more predictive of disease-specific and progression-free survival, and FDG PET could cause changes in the patient management in 25% of the cases in this study. The same group also an year earlier published the same data, and it shows that whether you are assessing single lesion or 5 lesion, the response evaluation criteria is pertinent. Another study from Patterson in Washington, and he compared the FDG with NEF, and it shows that the changes in the FDG PET parameters during therapy are predictive of time of skeletal related events and total progression, time to progression, and overall survival, but not overall survival. On NEF PET was associated with overall survival, but not predicting time to progression or time to skeletal related event, but that was not true when it was normalized for the normal bone uptake. Another study from Olener, again from Sloan Kettering, it shows that there is a 30% variation if you go from RESIST to PERCIST in terms of the grading of the response from stable and partial response to the complete response. There are 2 studies which are published in this year in 2020 from Denmark, And these are prospective trials of 87 patients which were able to receive first-line systemic therapy. FDG PET and contrast enhanced CT were both read separately, and PERCIST nadir scan was used for comparison with the RECIST 1.1 with a median follow-up of 15.9 months. There was a difference in progression of disease was first seen in PET in 78% cases, and PET has a 6-month lead time as compared to the contrast enhanced CT, and baseline measurable disease was seen with PERCIST in 87% of cases versus 53% of the cases with RECIST. The same group published another data, and this was on the basis of progression-free survival and disease-specific survival. Again, on 4-year basis, the responders and non-responders were statistically different. In terms of interim PET scan, the patients classified and post 2-cycle FDG PET responders using PERCIST as significant higher 2-year progression-free survival as well as overall survival. The PERCIST is useful for predicting pathological response in prognosis and neoadjuvant chemotherapy, and an optimal percent decrease in primary tumor SUV peak was 83%, was found to have sensitivity of more than 77% with equal specificity and predictive value. However, there are some challenges with the PERCIST because it's a complex analysis, and there are technical challenges like partial volume effect, physiological variation, acquisition errors, and suboptimal signal to noise ratio. Difference in various scanners, softwares, and standardization is yet to be, and again, it is available but not acceptable or utilized. Now, the advantage of PERCIST is a high degree of repeatability, less inter-observer variability, differentiate active tumors from post-therapeutic changes. It's able to assess metabolic activity in osseous or non-measurable diseases. It detects response progression earlier, and it classifies patients with static disease with progression disease more accurately, and there is a good correlation with time to event measures.
Sir, 2 minutes to
this
one.
This is the last slide. PERCIST seem to be feasible to response monitoring in patients with metastatic breast cancer. PERCIST provide a semi-quantitative response categorization with useful variable of SUL peak rather than SUV max. PERCIST result in most powerful and independent predictive of survival, and PERCIST parameters predict pathological complete response with moderate accuracy, which affirms that they are predicting value in neoadjuvant chemotherapy. Interim imaging performed during the treatment course may segregate responders from non-responders. Thank you.